Hi, my name is Dr. Murray Pollack of Children's National Medical Center. Thanks for joining us for this Functional Status Score training session. We're so glad you're here. The Functional Status Score, or FSS, was developed to measure the changing functional status of children before, during, and after hospitalization. The FSS is a rapid, reliable, quantitative, and objective measurement tool for discharge status, follow-up, and has been used extensively in research. The FSS was developed within the Collaborative Pediatric Critical Care Research Network of NICHD of the National Institutes of Health. It has been published and used in studies of over 10,000 children. Data may be recorded by the bedside caregiver who knows the child, or by data collectors using information in the electronic health record. Data collectors may also talk with the caregivers. If you are not the caregiver, you do not need to interact with the parent. Remember, you are an expert in assessing children. Since it's impossible to create scales that fit all possible situations, if something does not fit perfectly into the scale for an individual child, use your best judgment. The scale measures 6 main functional domains: mental status, sensory functioning, communication, motor functioning, feeding, and respiratory status. Functional status for each domain is categorized and scored from normal with a score of 1 to very severe dysfunction, which is scored at 5. If you are reviewing a case and the child is said to be normal, or if a domain of functioning is recorded as normal, believe it, you do not need to further justify this designation. The first domain is mental status. In this domain, normal is reflected by normal sleep-wake cycles and social responsibility, while mild dysfunction may be sleepy but responsive. Moderate dysfunction may appear as lethargy and irritability, while severe and very severe dysfunction may manifest as minimal arousal to stimuli, stupor, or a child in coma or a vegetative state. The sensory functioning domain refers primarily to hearing and vision capabilities. Normal refers to intact hearing and vision, and normal responsiveness to touch. Unless a problem is noted, please assume normal. Normal includes normal functioning with hearing aids or glasses. For mild dysfunction, you might suspect hearing or vision loss in one or both eyes or ears. For moderate dysfunction, a child is either not reactive to auditory or visual stimuli. The child seems blind or deaf in one or both eyes or ears, but not both deaf and blind. Severe dysfunction is a child who is both deaf and blind. And very severe dysfunction in the sensory domain is a very abnormal response to touch. While this is uncommon, it is severely abnormal. Examples include decerebrate posturing, decorticate posturing, spinal withdrawal, and no response to painful stimuli. The third domain is communication. Normal communication refers to appropriate vocalization and interactive facial expressions. If there is no mention of communication problems, assume the child is normal. A child is scored as 2 if there is diminished vocalization and or diminished social expressions, whether they be facial or verbal. Moderate dysfunction in a child refers to the absence of attention-getting behavior, while a score of severe dysfunction indicates a child who will not demonstrate discomfort. Very severe dysfunction is the complete absence of communication, as in a child with coma or in a vegetative state. The fourth domain is motor function. Normal refers to coordinated body movements, normal muscle control, and normal awareness of body positioning. A child scores at a mild dysfunction if there is functional impairment of one limb, while moderate dysfunction or a score of 3 will be functional impairment of 2 or more limbs. This impairment may be innate to the child or may include things such as taping an arm or a hand to an arm board that interferes with functioning. Severe dysfunction is indicated by poor head control, usually a sign of severe hypotonia. And very severe dysfunctioning is a child who is paralyzed and/or exhibits decerebrate posturing or decorticate posturing. The fifth domain is feeding. Normal feeding indicates food is taken orally with age-appropriate help. Mild dysfunctioning in this domain includes either nothing by mouth or NPO, or oral feedings with a special formula, such as those with increased caloric density. These indicators for special formulas are usually in the orders, in a nutritionist's note, or in the RN note. Moderate dysfunctioning for this domain is characterized by the need for both oral and tube feeding, while severe dysfunctioning for this domain is indicated by feeding with or without IV or parenteral nutrition only by a feeding tube. The most severe or very severe dysfunctioning for the feeding domain is IV or parenteral nutrition beyond regular D5W or regular IV fluids, usually with a fat or a protein supplement. The final domain is respiratory status. If there is no mention of respiratory support, assume normal. Normal means that the child is breathing room air with no extra oxygen, no artificial support or aids. Mild dysfunction in the respiratory domain is categorized by the use of oxygen, either by nasal cannula, by face masks, or by other devices. Tracheostomy is a key indicator of moderate dysfunction, while very severe dysfunction indicates continuous positive airway pressure, or CPAP, for all or part of the day, and/or mechanical ventilation support for part but not all of the day. Finally, very severe dysfunction is the child who needs 24/7 mechanical ventilatory support. The FSS is a relatively quick and simple way to characterize the functioning of children in specific domains. 2 points to sum up this brief introduction. First, remember that normal is normal. And second, trust yourself. You know children. Use your judgment to assign their functioning to the most appropriate category.